Very good. Welcome, everyone. Welcome, welcome, welcome. One moment, just getting the Facebook Live going. My apologies, it's taking just a little bit longer to load than usual. Morning, everyone, again, and good evening. Hey, let me introduce to you our speaker today. Dr. Abhishek Mangeshikar is the endometriosis excisional specialist who has actively taken up the cause of spreading awareness about endometriosis through the Indian Center of Endometriosis. ICE is a one-stop destination for all the information on endometriosis. It is a knowledge bank about endometriosis, providing one with the myths and facts on endometriosis. Ample research data, white papers, key developments in the field of endometriosis in India and around the world, frequently asked questions, treatment procedures, and more. Coming from a family of gynecologists, Dr. Abhishek's inclination towards the subject is quite evident. Having trained extensively in laparoscopy in one of the most advanced centers for gynecological endoscopy, Dr. Abhishek has worked in private practice for a year alongside his father, Prashet Mangeshikar, after which he underwent a 2-year fellowship in minimally invasive gynecology from Changyang Memorial Hospital in Taiwan. He has performed more than 250 surgeries, including traditional laparoscopy, robotic surgery, single port surgery, and natural orifice transluminal endoscopic surgery. Dr. Abhishek has been teaching laparoscopic gynecology and is currently a faculty at CMAS Mumbai, the Kiel School in Germany. And he has also recently been appointed to the board of the Asia Pacific Association for Gynecologic Endoscopy and will course conveyor for their courses run in India. Dr. Abhishek has also been faculty at various international workshops, including uh, EarCat in Taiwan, Alexia, Alexandria, and Foshan, China. Dr. Abhishek firmly believes that it is important that Indian women are aware about endometriosis and its symptoms. Lack of awareness, prompt diagnosis, and incorrect method of treatment are key challenges in India. Through ICE, Dr. Abhishek aims to not only spread enough knowledge about the disease, but also bring the relevant communities and stakeholders together to create a revolution in the field of endometriosis. His vision is to initiate a synchronized effort between stakeholders, facilitating a quick diagnosis and precise treatment for the disease. And without further ado, we bring to you Dr. Mangeshikar.
Thank you. Thank you, Alicia, for the introduction and for the invitation to speak. And you all are doing wonderful work pretty much across the world from where I am currently. So this is very different from what I normally do. It's usually to medical practitioners, and I do some uh, talks and endometriosis awareness campaigns for non-medical practitioners. So I want to keep this as informal as possible. I encourage as many questions as you can come up with. There's no such thing as a silly question. So please go ahead and put your questions in the chat box, or I'll be around for as long as you need me to at the end, where we can kind of take on everybody's questions on a live one-on-one kind of situation. So without further ado, I'd like to do my presentation, which is the basics of endometriosis. Of course, this topic was for awareness of endometriosis so people understand the basics of the disease. It's probably one of the most common diseases in the world. You know that diabetes is 1 out of 10, and the most recent statistics have shown that endometriosis is 1 out of 7. So I'm going to start with this little illustration from the Lily, which really kind of chronicles what the average patient may go through. Now, this is not typical for everybody, but it does kind of create the timeline and paint a picture in a more lucid way of what people can understand. So this lady chronicled her own experience, and she said she got her first period when she was 12, and it was dreadfully painful when she thought something was wrong, and her mother had to pick her up from school. And then if you look at the top right, that image, this is one of the classic signs I see in many patients where they get burns on the skin from continuous use of electric blankets or heating pads or hot water bottles. So this is a pretty much almost diagnostic of the presence of endometriosis or adenomyosis. Then we know that there are many other symptoms that come to this, and these are very interesting symptoms, which I'll speak to on the scientific basis of why it happens. While many young adolescents will just have cramps or bloating, which are not debilitating, there are extreme cases when they can become physically ill, nausea and vomiting, blacking out, and painful bloating. So these young ladies can only wear like track pants or pajamas during that time. So why do people get nauseous or lose consciousness during this? Because the pain is so intense. It stimulates the nerve fibers, which we understand from neuropelviology. When we have the superior hypogastric plexus and the inferior hypogastric plexus in the pelvis, which is right underneath the uterosacral ligaments, that time, if there's disease in that area, stimulation of these triggers a kind of vasovagal response, which is like akin to getting hit really hard in the solar plexus. So it becomes extremely painful. It induces nausea, can induce loss of consciousness. And because it troubles the intestine so much, because it's inflammatory, there is trapping of gas in there, which causes the bloating. So, continuing with her story, her mom took her to the first of several OBGYNs who didn't really do many investigations. They just prescribed birth control or painkillers like paracetamol or acetaminophen or Tylenol. So, and a lot of gaslighting happens at this stage, especially with adolescents. And as she obviously got older, the periods and the symptoms got worse. And then there came in food insensitivities, the dreaded endobelly where you look pregnant, and even breathing hurt. So, and then, as is par for the course with most endometriosis patients, they go to different doctors. And she looked at 9 different doctors looking for answers, and they get everything from, bad periods happen, grow up, deal with it. It's part of becoming a woman. Another one will say, let's induce menopause, let's stop the periods. And it's IBS because of bowel symptoms. That's the most common misdiagnosis. Or they're just pushed towards hormonal therapies or told silly things like get pregnant and the disease will disappear. And endometriosis occurs basically when there is tissue that resembles the lining of the endometrium, which is the lining of the uterus. It's not the same thing as the endometrium, which occurs outside the uterus and the pelvis as well. It can grow anywhere in the body and can cause a host of symptoms, not just pelvic pain. So we see a lot of migraines and headaches, fatigue, chest pain is usually, or diaphragm pain or shoulder tip pain can associated with diaphragm or thoracic endometriosis, sciatica, lower back pain, pain during the period, pain outside the period as well, painful bowel movements, which is called as dyschezia. Sometimes if it invades all the way through the bowel, it can cause rectal bleeding as well. Severe painful bloating, pain during urination, pain during intercourse, and pelvic pain and leg pain. So it's much more severe than a bad period. And by the time this young lady was 25, she had already been on 7 different types of birth control, including the combined pill, the progesterone pill, the IUDs, and different kinds of things that are available. Very severe food allergies. Oh, it definitely affects school and academic and as well as social aspects of one's formative years, and has been to the emergency room multiple times. And then this should obviously discover this is where the endometriosis advocacy groups and the support groups come in and play a really important role. And that's why also we created ICE to spread awareness about the disease. And then they understood that the endometriosis is a very severe disease which needs its own subspecialty. And it's not just about being seen by a regular GYN. It is a disease that is far more complex, one would argue, even more complex than gynecological cancer. Yet you find this inertia among the gynecological community to recognize endometriosis as a subspecialty. Now, for this patient, it took 14 years to get a diagnosis, but we look at statistics, we know that it can take anywhere 7 to 10 years, depending on which part of the world you live in. And we know that excision surgery, which is what I'm going to talk about, is going to get rid of the disease and improve quality of life. And it's not a one stop fix all. There are other modalities that are adjuvant and help with the recovery process. So let's start with the basics. We already discussed that it can occur anywhere in the body, most commonly in the pelvis, but extrapelvic disease is not rare. So it can occur in the ovaries, bladder, bowel, appendix, skin, diaphragm, liver, lungs, heart, brain, chest, and pleural cavity, as well as muscle. So there are many theories on the cause of endometriosis. The most common but a very unlikely theory would be the retrograde menstruation, which is the blood flowing backwards. Now we know that almost all women have retrograde menstruation, but not all of them develop endometriosis. So, and retrograde menstruation doesn't answer questions to how one can have endometriosis in the thoracic cavity, in the chest cavity, without having disease in the abdominal cavity or in the abdominal side of the diaphragm. So it's not the answer to what causes endometriosis. There are other theories like it is definitely genetic and there are epigenetic factors that influence how it develops, where it develops, why it develops, and which how severely it grows in one individual, whereas it may be a milder form in others. We have mulariosis, mularianosis, metaplasia, and different theories combined together. So what we need to know is that it's divided into three categories essentially, which is ovarian, which are the most commonly seen chocolate cysts, which are the easiest to diagnose. But one should know that if you have a chocolate cyst, it never exists by itself. It's always accompanied by peritoneal endometriosis or deep endometriosis. So that's what we have. We have ovarian, which is the chocolate cyst, and we have superficial, which is peritoneal disease, or deep endometriosis, which are the nodules of the disease. And obviously, it can affect the bowel, it can grow outside the pelvis, and you have all of those. So if you look at the top image, that shows a seemingly normal looking pelvis where you have the uterus on top and you have the two white structures with the ovaries on either side, and the bowel is below, that's the rectum. And if you see that little inverted U, that's the pouch of Douglas. And if anybody has ever read an op note which says pouch of Douglas obliterated, that means that the rectum is stuck to the pouch of Douglas and there's very likely bowel endometriosis in there. That should never come as a surprise finding at laparoscopy. That should always be diagnosed preoperatively, which is why it does require even specialist imaging to make the diagnosis properly. So if you look at the bottom picture now, that's completely different from the one above. This is what a frozen pelvis looks like. So you can kind of see just the top half of the uterus there, and you have kissing ovaries down here where the ovaries are stuck behind the uterus. The pouch of Douglas is completely obliterated because the rectum is stuck up there as well. And you have no access to get into the pouch of Douglas here. So this is obviously a more severe form of the disease. Now, many people, when they do an intake in a regular gynecological practice, the only screening question for endometriosis is, do you have painful periods? But we know it's not that quick. It takes me a good 40 minutes or 45 minutes to have an intake of a patient because we need to understand that it's not just a painful period. There can be abdominal pain, there can be pain during the period, pain outside the period. If there's pain with sexual activity, we need to know if it's pain on insertion or pain with deep penetration or certain positions that can be painful, like there's a wall being hit at the back of the vagina, which will give us more insights into where the disease may be. Of course, it can also be related to infertility or subfertility or difficulty getting pregnant. Chronic fatigue is very commonly seen with endometriosis and adenomyosis, as well as bloating. So pain during ovulation, which is outside the typical Mittelschmerz kind of pain when the ovary is released, because if the ovary is stuck, it's irritating the peritoneum where it's stuck to, and that causes pain during ovulation. Of course, you have also pain with bowel movements, and you can have constipation or diarrhea during the period, or you could have both, which is a very, very bad sign. Pain during urination, pain in the pelvic region, lower back, and or the legs. If it's one-sided, it's usually gives us a clue that we might find disease in one particular area. And then you have urinary issues, which are nerve-related, not necessarily being in the bladder itself. It can be where the nerves that supply the bladder are. So that is incontinence, unable to hold the bladder, going frequently to pee, frequent urinary infections. And the most troubling symptom is when the patient has to push down to empty the bladder and they have an incomplete voiding of the bladder. That's a very, very urgent sign for surgery. Also, you have it in you can have headaches that start in the skull and migrate. You can have under the rib cage or at the tip of the shoulder. That can be indicative of diaphragm or thoracic endometriosis. You can have abdominal pain, which can radiate from dull and achy, and it can be like a belt, or neuropathic pain, which is where the patient will take one finger and be like, it hurts right here. So there you know you can have a nerve involvement versus visceral pain, which is more like a belt and diffuse presentations. And then you can have pelvic pain, which can again range in motion to radiating to the lower back and down either of the legs. Now, even when it radiates down the legs, whether it's the front of the thigh, the back of the thigh, the inner thigh, and the nature of the pain, whether it's a dull, crampy pain, a sharp, stabby pain, an electric pain, or burning pain, all of these symptoms give us clues to what kind of disease we're dealing with. if it's compression of a ligament, or if it's compression of a nerve, those kind of diseases will present in different ways. So sciatic nerve is the pain is typically starts at the butt, goes down the hamstring, and that it presents a sciatic pain. And it's obviously usually the patient will be sent to pain management or orthopedics to look at something, and they do a spine imaging, and it's normal. And this sciatic pain is not necessarily only coming from disease on the sciatic nerve. Sometimes when you have disease in the pelvis that grows into the pelvic sidewall, there are root values that supply the sciatic nerve, which are S2, 3, 4, 5, and those can radiate pain to the sciatic nerve, to the bladder. So when you get a combination of symptoms, when you take the patient's history, you can automatically start to predict where you're going to find lesions and then obviously confirm that with the imaging. This was a very interesting study in the BBC in 2019, which looked at something close to 20,000 patients and looked at their quality of life. And 84% reported a decrease in quality of work and not able to achieve academic or career success because of the pain. And 20% reported being temporarily disabled. 40% reported stunted career growth due to chronic absenteeism and underperformance. 3% were totally incapacitated and unable to do anything. 1% had attempted suicide at some point, but even 40% or so had thought about it at some point as well. So then thought did cross them out. So those are quite alarming statistics if you look at it. Now we know that diagnosis can take quite a while for the average patient. And this is the typical amount of pitfalls for the endometriosis patient. They're told that when they're seen in emergency departments, they're pushed off as drug-seeking behavior, hypochondriac, paranoid, frequent flyers, non-compliant. And there's failure of support for these young patients from peer groups and family support systems. There's gaslighting that happens in the medical community as well as in the family structure. They're taunted and teased and told that, oh, don't be a baby about it. And, it's part of growing up. Pain happens to everyone. And these are stopping people from coming forward to get treatments. And that is a huge problem that needs to be addressed. And among the gynecological community, unfortunately, the myth still persists, and they're told to get married and have babies. And of course, the glaringly obvious gender pain gap that men in pain are taken more seriously than women in pain. So it's very important how we diagnose endometriosis. The most important tool for the diagnosis is not an ultrasound or an MRI. It's actually to listen to the patient. The patient will actually kind of tell you what the diagnosis is, just the way they talk to you and tell you where the pain is. And I think it's more important to listen to someone and validate their symptoms and not dismiss them and try to rush towards imaging and say, okay, your ultrasound is negative, you can't have endometriosis. It's more important to listen to the patient, and that good half an hour that you spend talking to the patient and listening to what she's saying is going to give you clues to where the disease is. So a consult, when I do it, can take upwards of an hour for sure, including the physical examination, the pelvic examination, the ultrasound that I do myself, or the MRI, which I also read myself. So all of that, and then explaining to the patient what's going on with her, and then what needs to be done, presenting those options is not something you can do in a general OBGYN practice. Obviously, if you're seeing 100 patients in a day, or even 20 patients in a day, and you cannot allocate enough time to the endometriosis patient, who needs to schedule that amount of time with you? So if they're rushed in and out of the doctor's office in 15 minutes, there's no way you can make the diagnosis. So we need to understand types of pain and their location and the detailed history. Usually endometriosis patients, when they find me, have obviously gone through the rigmarole, and you have to go through a lot of what was done to them and kind of get to the bottom of it. So you have to really prepare the case well. And if possible, do a gentle examination. A lot of these patients have a history of trauma from medical examinations and other traumas, and also from vaginismus because of the nerve pains, as well as deep pain from disease that's there. So one has to be very gentle when making an examination. And then, of course, imaging does play an important role in the diagnosis, but we're going to speak about that because imaging is very operator dependent, and who is doing the ultrasound and who is reading the MRI. So for me, it's very important that if I'm doing surgery, I need to be able to do the ultrasound myself. and able to read the MRI myself because the radiologist has never been to the OR and they have never done that kind of surgery before, so they don't know what they're looking at half the time. So when it comes to treatments, we know that medical therapies that are available are for symptomatic treatment. It's not treating the disease. Medication that's available on the market today is treating symptoms, whether it's pain or other kinds of symptoms. So you obviously have your pain medications with the NSAIDs, so non-steroidal anti-inflammatory drugs, or opioid medications, birth control, which is hormonal, and then you have progesterone-only pills or the combined pill. You have the injectable GnRH, and now you have oral GnRH. And you have alternative medical therapies like acupuncture, hydrotherapy, cognitive behavior therapy, so on and so forth. Now, when it comes to surgery, it is not all surgery is equal. There is ablation, there's excision, there's even among the excision surgeons, there's different levels of excision. There's probably a handful who can handle very advanced disease. Now, it's technically more difficult than cancer surgery, and I can speak to this from a position of authority because back in the day, I used to kind of focus mainly on gynae oncology. And then when I moved to endometriosis, I realized that I did not know much about it, and I had to relearn everything from the ground up. So we know that surgery dramatically improves quality of life in most patients. This was a study that showed that the pain scores went down from an average of 8.5 to 1.4 post good surgery. Now, we talk about excision, we talk about ablation. So ablation is a silly thing because the surgeons who perform ablation, who are usually general gynecologists, who also deliver babies, who also do some hysterectomies, who also do fibroids and everything of the sort, they're not going to do justice to the endometriosis disease. When it's close to the ureter, close to the bowel, they're saying, okay, it's too dangerous for us to cut out, so we're going to burn just the surface of the disease and stop. Now, obviously, when you burn the surface, you don't know how deep the nodule is going. And you're obviously not going to burn deep enough because you're going to damage the vital structure. So it's very important for the excision surgeon to be able to get around the disease and move those structures away from the disease. Or sometimes if it's invading those structures, we have to be prepared to cut through those structures and reconstruct them as well. So if you have a bowel endometriosis, you have to be prepared to do a bowel resection. If you have it infiltrating the ureter, you have to be prepared to either cut that ureter and reimplant it or kind of shave it off the ureter and stent it. So it's very, very highly specialized multidisciplinary surgery. So outside the realm of regular gynecology. So if you look at these pictures, this is a laparoscopic view. We're starting at the top left. So this is a laparoscopic view where we're looking at the left ovary. That little round structure there is the corpus luteum. So post-ovulation. And if you look below that, you see what looks like endometriosis in some spaces. So the most people would say there's no endometriosis. Most gynecologists would say there's no endometriosis. If they look a little closer, some will say, okay, there's a couple of powder burn lesions at the top, and they may just ablate that. But if you actually look really close, which is how close you need to get to make the diagnosis, is you have these hemorrhagic powder burn lesions up here, which are the typical classic textbook lesions. But you also have the other lesions, which are not so commonly described, where you have new blood vessels, which is a fancy word called neovascularization, which is the disease creates new blood vessels around it. It also creates scar tissue, which is why you see these white fibrotic lesions. And you see inflammatory lesions, which are clear vesicular lesions that look like little bubbles. So when you treat that, the excision has to remove all of the disease, not just burn those powder burn dark lesions there. So when we look at recurrence of disease, I'm sure many of us have read that endometriosis is a recurrent disease that has no cure. So when they looked at the literature between regular gynecologists, so all across the world, the recurrence rates were published to be 50 to 80%, which is ridiculous. When they focus the microscope on more endometriosis centers or specialists who performed exclusively endometriosis centers surgeries, the recurrence rates dropped down to the low tens or even single digits. So there were less than 3% recurrence rates for deep endometriosis and less than 10% for ovarian endometriosis. So this begs the question, why is there such a big difference between what endometriosis specialists are doing versus what general OBGYN is doing? And the reason is we diagnose it better. We can identify the lesions better and we can go deeper and remove it from its roots. So the recurrence rates are much lower. And I would argue that general gynecology recurrence rates are not true recurrence of disease, it's persistence of disease. I always tell patients, if you have appendicitis or if you have disease in the appendix, and I tell you, I'm going to remove a cyst from your ovary, no matter how many times I do it, you're still going to have appendicitis. So if you have endometriosis in the bowel and somebody just goes and removes the cyst, whether they do it one time or 100 times, it's not a recurrence of the disease in the bowel. It's persistent disease because it was either never diagnosed in the first place or it was never removed. Now, I like this slide because it really explains what the endometriosis patient goes through. Now, we're going to use this as an analogy of a patient with a splinter in the finger who walks into the office of different doctors seeking advice on this condition. The first doctor says, take these pills, this should sort out the pain. The second one says, I can't see the splinter, so it's all in your head, and your imaging is clear. The third one says, I'm just going to burn off the top of the splinter and the rest of the disease will die off. The fourth one says, I think we should remove the entire finger and possibly the hand. And the fifth one says we should remove the splinter in its entirety, including the root embedded in its flesh. So I think it's kind of obvious here, and this is obviously hyperbole. It's not as simple as this in real life. But I think this really strikes a chord with what the average patient will go through when they're trying to get to an understanding of their condition. This is a very interesting slide my friend Shaheen Kazali from the UK had made. And he said there are different camps in the OBGYN community. And at one end of the spectrum, you have the should not operate camp. They believe that surgery is never the answer for endometriosis. They should just give drugs and hope for the best and push the patient into IVF treatment. On the other end of the spectrum, you have treated like cancer camp who, and believe it or not, this is guidelines for ACOG, which is the American College of ONG, the Indian guidelines, and I also believe for the UK guidelines or the European guidelines that says that hysterectomy and removal of the ovaries is definitive treatment for endometriosis. Again, I come back to the analogy that for a disease that by definition exists outside the uterus, the indication to remove the uterus in the absence of uterine disease is unwarranted and should be re-examined as a therapy. Of course, if there's adenomyosis and fibroids, a hysterectomy may be warranted in those cases, but I'm talking about just endometriosis. And moving further, you have the incomplete excision gap camp, which says if you remove some disease, the rest will die out, which is ridiculous. The ablation camp, which says there's no evidence between excision and ablation, so they'll do what's easier. And one should all strive toward the complete excision camp, which is where we should remove the endometriosis completely within reason, taking care of reproductive function, neurological function, sexual function, and bowel and bladder function as well. So neuropelviology and nerve preservation is what's the order of the day today. So who should do surgery? Should it be laparoscopic gynecologists? Should it be fertility surgeons? Should it be gyne-oncology? And we know that none of these people are qualified necessarily to do advanced endometriosis surgery. So when they looked at studies that showed that inadequate treatments from even experienced laparoscopic surgeons, untrained in endometriosis surgery, were almost as high as 35%. And of course, it's not the urologists who should be doing it, neither should the general surgeons be doing this kind of surgery because it's outside their realm of understanding. So my question is, if you had a brain tumor, would you go to a general surgeon to get it done? Of course not. So there's the endometriosis as a subspecialty that is slowly developing around the world. And there should be high volume centers with multidisciplinary care in place. And they should be able to tailor the radicality of the surgery to the patient's needs and to the disease. So, of course, just to address some of the frequently asked questions before we jump into your questions, do I need a hysterectomy? Again, I said hysterectomy is not a treatment for endometriosis unless there is a concomitant uterine pathology. And disease which exists outside the uterus, the indication to remove the uterus in the absence of any uterine disease is unjustifiable, unwarranted, and must be re-examined. And this is listed as definitive treatment in most obstetrics and gynecology guidelines across the world, which really needs to change. And then there's this constant fear that all endometriosis patients are infertile and they need IVF. And this is a very common scenario we see in daily OBGYN practice is you have a 30-year-old with deep endometriosis, and then the doctor puts forth the Sophie's choice of questions, which says, what is your priority? Would you like to relieve the pain, or would you like to try and get pregnant first? And the question in itself is wrong, because the patient usually will say, okay, I'll try and get pregnant and we'll deal with the pain later. And then instead of treating the disease, they're pushed to treat the symptom of infertility and say, okay, we're going to push you into IVF, which obviously many patients will report that, when IVF in the presence of endometriosis is horribly painful because you're hyperstimulating the ovaries, and that is going to cause a lot of exacerbation of symptoms. And obviously, the IVF successes in the presence of disease is drastically reduced. So the question in itself suggests that the two goals of treatment cannot be attempted simultaneously. There's enough evidence now to show that removing the disease not only improves pain, but it also improves pregnancy rates. And there's a great study by my professor and mentor, Horace Roman, which shows that for colorectal endometriosis, which is deep endometriosis of the bowel, so that excision allowed conception rates of almost 80% within the first year after surgery. And out of that 80%, almost 60% delivered naturally, conceived naturally. And the other 40% of those 80% required ART. And the next study he did after that was patients who required IVF. They were randomized to having IVF without surgery and surgery followed by IVF. And they found that the IVF group fared less successfully than the group that had surgery followed by IVF. So it's almost logical now to remove the disease first, which will help whatever the patient needs in terms of pregnancy outcomes, as well as give them quality of life back so they can enjoy living life without pain. They can enjoy having intercourse without pain. And those are very important things to consider as well in the fertility journey, as well as quality of life. And why does medical therapy fail? Because medications for endometriosis just aim to suppress estrogen. They suppress estrogen-related flare-ups, so there's a transient absence of symptoms. This does not work for everyone, but it has no impact on regression of disease. So it's hormone dependent and not only estrogen dependent. And we know that endometriosis can make its own estrogen in spite of being in suppression. Therefore, pregnancy or menopause are not cures for endometriosis. So does pregnancy cure endometriosis? Of course not. And I hope that this myth is slowly dying out, but I still see it every day rampant among the OBGYN community. And when I see patients, many of them will tell me that they've been told to get pregnant as a treatment for this disease. So we need to address these causes where medical education has failed. We've got wrong definitions and causes of endometriosis taught in medical school. Endometriosis, surprisingly being the most common disease in the women with chronic pelvic pain, is at the bottom of the list. They treat random things like pelvic inflammatory disease, which is much rarer than endometriosis. So if it looks like a duck and it quacks like a duck, it's probably a duck. So we should put endometriosis at the top of the differential diagnosis. And what's taught in med school is if you have a patient coming through with pelvic pain, just give them hormonal suppression first of all, without looking for a proper diagnosis, which is extremely dangerous if you have, a bowel nodule that is going to cause a block or something that is compressing the ureter and can cause a kidney to fail. I end up removing somebody's kidney every couple of months. So this is not a rare thing. It does happen very commonly. And there is no training curriculum for minimally invasive surgery, at least in India and postgrad. It's changing slowly, and let alone endometriosis as a subspecialty and learning to recognize that. There is no rotation for postgraduate training through an endometriosis center. So it really does require one to take that upon themselves to kind of improve that. So what can we do as endometriosis patients, as advocates? So we know that pain that is debilitating, that is causing loss of quality of life, is not normal. We need to stop normalizing pain of that kind. We need to look to getting specialist referrals and creating awareness programs within the community. And there should be partnerships between patient associations and recognized endometriosis centers. This is a double-edged sword in that, they're just creating endometriosis centers for the namesake, and there's still a lot of disease being missed. We see this in some of the public healthcare systems. And then primary care physicians, who are the first point of contact in some countries, should be able to, be given the tools to help diagnose and recognize symptoms and direct them towards specialist care. And the goal of ICE, which is the Indian Center for Endometriosis, was to be a knowledge-based resource to put out correct information, not just for patients, but also for medical practitioners, to help identify not only specialty centers, but to help identify symptoms and direct patients to care. So that's why we launched the center. And this is, if anybody's interested in looking at it, this is the website. And this was what our vision was. It's been almost 8 years now, and hoping to grow it, and it has grown quite well. And I thank you for your time, and I will open up to questions. These are my socials if you need to get in touch with me or for information on endometriosis and adenomyosis and so forth. Thank you.
Thank you so much. That was an amazing presentation, very informative. Thank you so much for joining us. Kimet, would you like to start with the questions in the chat?
Yes, I would. Also, I'd like to say thank you so much to Dr. Manishika. I was also enlightened, and I really loved your slides, right?
Thank you.
So we're starting with the questions in the Zoom chat. We have quite a few. The first question is, I'm in the public healthcare system. Ultrasounds have to be done. Nothing found. Ultrasounds, sorry, have been done and nothing has been found. I've been sent to the fertility clinic. How can I self-advocate for further workup? Should I push for an MRI?
Or laparoscopy? That's a great question. So yeah, this is a very common. I'm glad you asked this question. This is a very common problem that we see. So, like I said, imaging, like surgery for endometriosis, is very, very skill set dependent. So it really depends on the ability of the person doing the ultrasound or the person who's reading the MRI to kind of pick up the disease. Most ultrasound techs or radiologists who read MRIs will kind of only comment about cysts in the ovaries, and maybe adenomyosis or fibroids and stuff like that. That's the stuff that's easy to see. So if somebody doesn't have disease that is not an ovarian cyst of endometriosis, they kind of get missed in the diagnosis. They're not, so if you look at the standard ultrasound report, they pretty much look at the uterus, they look at the ovaries and call it a day. But an endometriosis protocol ultrasound looks at the anterior compartment, the middle compartment, the lateral compartments, and the posterior compartment. What that means is it looks at the bladder and the ureters going into the bladder. It looks at the uterus, the ovaries, and the pelvic sidewall to an extent. And it also looks at the rectum and the areas below the ovaries, which are the lateral walls. Now, all of this is quite a comprehensive ultrasound, and you have to not only just look at the uterus and the ovaries, you also have to check for the mobility of these compartments over each other, which is called the sliding sign, where we look at if the uterus moves freely over the rectum, and that's called a good sliding sign, a positive sliding sign. If it's absent, that means the rectum is stuck to the uterus. That's the first sign that there is disease in the posterior compartment. And when you have an absent sliding sign, it's pretty much automatically stage 4 endometriosis. And when you look at the ovaries, and if the ovaries have no movement against the uterus or against the pelvic sidewall, that means the ovaries are either stuck to the uterus, they're stuck to the pelvic sidewall, and if there's tenderness there, that's usually because of endometriosis. So that's another sign that in spite of not having a cyst in the ovary, there can be endometriosis around the ovaries. So, and then we are able to actually look at the rectum and kind of see if there's a nodule in there. Again, this is very highly subjective. So this is an ultrasound protocol. For the MRI, you can also see a lot more laterally, and you can see higher up in the bowel. So if it's in the sigmoid colon or in the upper parts of the intestine, you can see that as well on the MRI. But then again, even if there is expert imaging done, it does not rule out peritoneal disease, which is the where you looked at my slides. That cannot be picked up on imaging. So then, if the patient's symptoms fit the profile, then a laparoscopy may be indicated, not just to diagnose it. It should not just be a generic laparoscopy. It should be done, again, by an expert who, even if they find disease, they should be able to remove it at the same time. So diagnostic laparoscopy is pretty much dead. But if a laparoscopy is being done, it should be to cure, to remove the disease. Okay, I hope I answered that well enough.
That was fantastic. Thank you so much. Kimet, would you like to go on to the next question?
Yes, sorry there. I was having some issues. So the next question. Thank you for that distinction, doctor, and for emphasizing the specificity. as well as the need for expert reading in that sense.
Yeah.
So the next question is, can excision of ovarian cysts 7 cmc cause infertility or loss of eggs?
Oh, so yeah, that's a great question. So I think the question is if a 7 centimeter ovarian cyst cause infertility or loss of eggs. So if you have a 7 centimeter endometrioma, it's very unlikely that there is no other disease there. So it's very important not just to treat the endometrioma, but to treat the underlying disease. So the ovary is usually stuck to the pelvic sidewall, under the ureter, to that whole thing. And that sidewall needs to be excised as well, and whatever other endometriosis there is. So removing a cyst can cause a transient loss of follicles. So it can have some impact on the AMH. Usually, this is very operator dependent. So it depends really on the skill of the surgeon to be able to remove that cyst and separate it from without damaging the ovary too much. In my practice, I find that the robotic surgery, I also do laparoscopy, but I find the robotic surgery gives us a little better vision and a little more delicate instrumentation to make sure we have less damage to the ovary during surgery. And that being said, even when a cyst is removed, the damage is transient. It does recover over time. And more importantly, the presence of a cyst and endometriosis is itself damaging to the egg quality and to the implantation of eggs. So it is almost, in my opinion, mandatory to remove the disease in spite of the potential risk of damage to the eggs. It will not cause infertility, but it is very important to remove the disease. There are other modalities also now which are like sclerotherapy, where they put alcohol into the ovary rather than removing the cyst wall. But I do think it has obviously less damage than removing the cyst wall, but I also think it has a slightly higher recurrence rate. So again, these things have to be discussed with the patient, and then looking at all the factors like the AMH, the follicle count, and what that is, to kind of help them reach a tailored therapeutic regime. More importantly, I do want to stress that everybody, including fertility specialists, get really hung up on AMH, and they start driving that. So one needs to understand that the AMH is only really important for an IVF cycle. So a patient with a lower AMH is more suited to natural conception rather than a success at an IVF outcome. So it's very important to kind of make that distinction and create that awareness even among the gynecological community.
Okay, thank you, doctor. So moving straight along with the questions, because we have quite a few. Is it possible to diagnose endometriosis with just an ultrasound? And how would one know what stage they're in? I was diagnosed just I was diagnosed with just an ultrasound and was put on birth control immediately. I basically don't know what I'm dealing with exactly. My gynae said that surgery might not be necessary. I would also like to know how having, a retroverted uterus impacts endometriosis.
Okay, this is a bunch of questions. I'll try to answer each point. So yes, it
Yeah.
is possible to diagnose endometriosis with just an ultrasound, but like I said, it really depends on how good the person performing the ultrasound is at doing the ultrasound. If they're going to give you a full, detail about every compartment, and you probably would use an Enzian score at the end, which is a staging system that's different from 1, 2, 3, 4. There's also the AAGL staging system, which doesn't refer necessarily to 1, 2, 3, 4 in the traditional sense, what the old system used, which was the ASRM, which was the American Society of Reproductive Medicine. There's an app now where you can use your ultrasound base. So you have to kind of look at all those areas on the ultrasound and put that in, and it calculates the score. And then you can correlate that with what you find at surgery. And it does work quite accurately. But again, this is heavily dependent on what the ability of the person doing the ultrasound can accomplish. So like I said, in your case, I don't want to talk specifically to your case, but we see this very often that an ultrasound is done. Maybe they pick up a cyst or something like that, and then they put the patient on birth control, which is not treatment of the disease, it's treatment of symptoms. So usually when you have some disease that's picked up, surgery is probably inevitable at some point, especially if the patient has symptoms. Uh, and medical therapies are a way of buying time until the patient can get into surgery. That's not really a treatment as such. Speaking to a retroverted uterus, one needs to understand whether the uterus is naturally retroverted, which is normal, or if there's a retroflexion occurring because of disease between the back of the cervix and the body of the uterus. So that's an anteverted uterus, which may have retroflexion, which is kind of a bad sign. That means there's a big nodule at the uterine torus, which is where you would find the rectum stuck, or you would find rectovaginal disease. And that is usually associated with quite severe endometriosis.
Okay, thank you a lot there, Doctor. I learned a lot more with your response to that question.
Yeah.
So the next one comes from Shivani. Shivani says, I have grade 4 endo and consistent leg pain. Are doc here asked to take Diagnosed
Digest.
with
Yeah, that's the term.
Dinojet, sorry. Still till I want a child. Um, they told surgery shouldn't be done now as my AMH is low, 0.6. Basically, when should one go for surgery? Does surgery affect the eggs resolve?
Okay. So this is quite a classic scene that I see it every day. So stage is not great. Staging is something we see on imaging or at laparoscopy. Grading is something that is done under microscopy, which is used for cancer. There is no grading system for endometriosis. So it's stage 4 endometriosis, and consistent leg pain. So leg pain is usually a pretty bad sign, especially if it's one-sided. That means the disease is growing into the pelvic side wall and starting to affect nerves there. So it's parametrial disease pretty much, which is quite, in my opinion, the most severe form of endometriosis. I would argue that it's even more severe than bowel endometriosis. And this is what you kind of see typically in general OBGYN practice, because there was a dictum that said you should do one good surgery for endometriosis. It's not, and most gynecologists took it that you should delay surgery as far as possible. And now you see that surgery is only being done for women who are desirous of fertility. Now, mind you, only 30 to 40% of patients with endometriosis have fertility issues, while 90 to 95% have pain. So that means you are subjecting patients who never want to get pregnant to a lifetime of pain, which is a terrible way to proceed with this disease. And to delay surgery, to allow disease to sit there and grow, and the disease itself is already causing more damage to the ovaries. It's silly to kind of delay treatment and in the hopes of when you are trying to get pregnant, only then will they do a surgery. And if somebody is suggesting this, means they're usually going to do quite a half-baked surgery. In my opinion, a good endometriosis surgeon who's made the diagnosis will say, okay, I need to do this when it's an easier surgery rather than it's a more difficult one down the line.
Well said. Well said. The next question is, never had any symptoms, yet I was diagnosed with stage 4 endometriosis. Could you please suggest what kind of obvious symptoms to look for?
Yeah, this is a good question. And I should have spoken about it. So the stage of the disease, so 1, 2, 3, 4, has nothing to do with the symptoms or the severity of it. So you can have someone with peritoneal disease who can have the worst pain scores, and you can have someone with a frozen pelvis who can have no symptoms, which is quite interesting. So it is very important to understand the symptomatology. And like I said, most of the symptoms, what I covered, if those are there, so like any kind of pain, abdominal pain, shoulder pain, pelvic pain, bowel pain, pain with sex, pain with urination, leg pain, lower back pain, um, bloating, infertility or subfertility, those are symptoms that can occur. Ovarian pain, all of those symptoms can kind of start to lead to a diagnosis. But yeah, and one of the questions I get asked about this is, would you operate on a stage 4 endometriosis patient who did not have any symptoms? The answer truly depends on me explaining to the patient what the situation is. If there is any impending danger to an organ, then I would do surgery regardless, whether they had symptoms or not. So example, if there was a bowel nodule that was threatening an occlusion, then yes, very likely they would have bowel symptoms, but probably we misdiagnosed as IBS. And or if they have, for example, a hydroureter, which is when the ureter is getting blocked, which is damaging the kidney, then you kind of have to do surgery in an urgent thing, and this can happen with the absence of symptoms. So yeah, that's what I digressed a little bit, but those are the kind of symptoms we have to look out for.
Okay, thank you for making that statement and for showing us in terms of the stages and how that directly correlates to the symptoms. The next person says, "Thank you for an excellent and validating presentation." That comes from
Thank
Kalima.
you, Khalid.
Next person says, "Will ovarian tissue be removed while excision causing less eggs and infertility for unmarried?"
I think we kind of addressed that in the cyst question. So we
Mhm.
don't, so what we need to, move away from endometriosis being as just ovarian disease. There are more severe
More
forms of
than,
the disease,
yeah.
and the cyst is usually the easiest part of the surgery. So, but to come back to your question, yes, when you do remove a cyst, there is a theoretical risk of damage to some part of the healthy ovary, which should be minimized as far as possible and really depend on surgical expertise. But like I said, the cyst removal is usually the easiest part of my surgery. So it takes 20 minutes to remove the cyst, whereas something like removing the bowel nodule can take a good couple of hours.
Okay. And Vanshita says, "Is it the fact that restricting diet like gluten, dairy, soy, sugars help with inflammation? How do we plan our diet here?"
So so dietary evidence is kind of conflicting. I don't know what the great evidence on diet is. I don't necessarily propagate restriction of diet. Sure, if you have gluten intolerance, if you have sensitivity to dairy and soy and stuff like that, obviously avoid it. And if it reduces the inflammation, good. But there's no one size fits all in terms of diet for endometriosis patients. So it really is kind of tailored nutrition that works for some, doesn't work for everyone. So you kind of have to work with the endometriosis team and see what the nutritionist says and see what works for you, what doesn't work for you.
Okay, fair enough. Thais says, "I've had laparoscopy done, yet I'm still unsure because I was told they haven't seen anything. Still in bad abdominal pains. What should be my next step?"
Yeah. This is a difficult one to answer because we have no details of the laparoscopy. We don't know what kind of surgeon may have done it and whether they're able to identify all types of disease. So my advice would be if you still have pain, you should see an endometriosis specialist and kind of get more insights towards that.
Okay, okay, thank you. Jamila says, "Would you recommend egg freezing before surgery for someone with an AMH of 0.38 and kissing ovaries?"
That's a great question. Um, so egg freezing is like every fertility doctor's favorite thing to do now. There's this crisis now that everybody's eggs are dying and they need to be put in the freezer. So, no, I would not recommend egg freezing if somebody had kissing ovaries, especially if there were cysts in both the ovaries, because kissing ovaries means both the ovaries are stuck behind the uterus. And the next thing that's also stuck behind the uterus is usually a bowel nodule that's between those two ovaries. So, for them to get access to the eggs, if there are cysts in there, first of all, they'll have to put an ultrasound probe through the vagina and then drive a needle through there to get to the eggs. Secondly, they will also go through the nodule and cause some spill of the endometriosis cyst and cause some inflammation and possible. We've seen this that when they puncture through the ovary, they're damaging the quality of the eggs anyway because of the disease in there. And two is they create an infection in that cyst, which forms an abscess, which turns the chocolate cyst into pus now, which is horrible because then you get infection in a setting of endometriosis, which is, going from the frying pan into the fire. So yeah, I would absolutely, in a specific case like this, not recommend egg freezing, even though the AMH is low. I would recommend very careful surgery. And then, if needed, probably getting the eggs picked up after removing the cysts. I know this is a
Okay.
controversial thing to say, but uh, I know many fertility doctors would disagree with me. But yeah, I've been in the trenches, so I know how bad it can get when these guys do what they do.
Okay, understood. Understood there. We have a lot of comments coming in saying thank you, doctor, so much for the informative session presentation. I have one really good question here, and it speaks to what you were talking about in terms of the expertise of the person doing the imaging. So someone
Mhm.
asked, how do I identify if the person who is doing an MRI or ultrasound is doing a good job? Also, like if my ultrasound was fine, but because of all my symptoms, my gynae strongly suggests endo, and has prescribed hormonal pills, where do you go from there?
Oh, that's a good one. So, coming to the first part, the imaging, it's very difficult to figure out who is good at it. So, obviously, the like I said, because uh, I'm a bit of a control freak and I need to do everything myself. I do the ultrasound myself, so I had to teach myself how to do the ultrasound for endometriosis, and I also had to teach myself to read the MRI for endometriosis because the reports I was getting was not matching what I was finding in surgery when I was starting out. So I said, obviously, these guys are missing something. And then I worked with my radiologists in the hospitals and say, like, look, you guys are missing this. So we develop protocols to create what needs to be done to help them identify disease. So now they're very competent and very good at it. But I still do my ultrasound myself and I still read the MRI myself because it really helps me plan what I need to do. But there are also very, very good endometriosis surgeons who work with specialist ultrasound gynecologists that work as a team. So that helps them make the diagnosis. So they're very, very accurate with that. And yeah, but most of the big surgeons I know across the world will kind of do it themselves and read the imaging themselves. So they're not very reliant on other specialties to do it.
Okay, that makes sense, and it would help if the person knows exactly, what they
Yeah.
want to look for, what they're trying to get out of the imaging.
Yeah.
Just
Sorry.
making note
Was
of.
there a second part of the question that I kind of forgot?
I think they were talking about like what next steps, if they have the symptoms, but the ultrasound like is fine.
Right. I mean, you would obviously have to get a more comprehensive diagnosis. So I'll tell you what I do is if usually because I consult patients from pretty much all over the world, and obviously not everyone can fly into India to get an ultrasound done by me. So they can get an MRI in whatever country they're in and send me the imaging. So the MRI center will usually give you a CD or the images, and they can send it to me. And then I can review that. So I can sit down on a Zoom call like we are right here. I can share my screen and then open up the images and kind of walk the patient through the imaging myself. So they have really kind of understand where the disease is. It's very easy to understand an MRI if you know what you're looking at, even if as a non-medical person. So they can understand where the disease is and correlate with that with what symptoms they may be feeling.
Okay, okay. Thank you. We're keeping the questions general still, so I have just about two more
Yeah.
coming in. Someone says, I've found that the link between food allergies, IBS-like symptoms, and endo isn't well known. Thank you for mentioning it. Will these improve after endo surgery, assuming it is removed from the bowels?
Yeah, that's a great question. So usually my what I would tell the patient is the bigger the bowel nodule, the more immediate relief of pain and bowel symptoms that you will expect. So IBS, we need to understand what IBS is. IBS is irritable bowel syndrome, but it is a disease or it's a diagnosis of exclusion. Now, because the bowel endometriosis is so often missed that many patients are referred to gastroenterology where they will say, okay, you have IBS because they can't find anything else. So that not necessarily all patients with IBS have IBS. They may just have bowel endometriosis. Of course, IBS can also coexist with bowel endometriosis in its true form. And it's very important to be able to counsel someone that, yes, they may still have IBS symptoms even after excision once we remove the bowel disease. But that is in the cases of true IBS. And I think food sensitivities also do improve after removal of bowel endometriosis. Bloating does take a little more time because there's that, the bowel has its own nervous system and it's been like hyperstimulated for many, many years while that nodule has been there in the bowel. So for that to downregulate does take a little bit of time.
Okay, thank you. So for persons who have more questions, you can follow Doctor. He shared his details in terms of his social, so you can check those out. I just have one question regarding the ultrasound website that you mentioned. Someone is interested in getting that information. Possibly it was your website, I think they were talking about. So maybe if you
Oh,
could share that.
oh, for ultrasound, I mean, I have, I think on my YouTube, there's a couple of, I've done imaging for endometriosis. There's a lecture in there. So if somebody wants to go through that, it kind of shows that. Otherwise, you're welcome to reach out to me if you're a physician. I'll be happy to share knowledge and teach you how to do it. Or for a patient,
To share
there's
the knowledge.
material available online.
Okay, thank you so much, Doctor. Thank you. Now I would pass it over to Liz as we get into the raffle. But thanks again so much, Dr. Mangs. It was a very informative session, and I'm sure not only myself, but everyone who joined on, they learned a lot.
Oh,
A few things which we didn't know, but we
well,
gained that
thank you for
insight
having me.
through your presentation.
Thank you. And I must commend the people who tuned in. There were some really, really great questions that
There
I
were.
tried to cover most of it in my lecture, but I did feel like I missed out some things. And you really asked very pertinent questions. So thank you for making this very informative and a good crosstalk and back and forth.
Thank you. Thank you so much. So
Thank you.
handing over to you now, Liz.
Okay, thank you. Thank you, Dr. Mangeshikar. This was a really great presentation, and thank you everyone for being so active in the chat. It was made for a really interactive session. I'm also really great to hear from you, Dr. Mags, that the new staging system is working well. I know when it was first introduced, we all had a lot of hesitancy around it, but I'm very, very glad that it's become a helpful tool. So now I am going to share my screen so that we can do the giveaway. Share. All right. There we go. Okay, everyone can see? Oh, and Jamila has won our giveaway. Please send me a private message, but I'm pretty sure I have your email from the registration. And we will be getting in touch with you regarding getting your copy of Finding Peace with a Devastating Disease by Amy Corfelli. We'll stop the share. And thank you again, everyone, for joining us. Thank you to the doctor for an amazing presentation. It was a wonderful meeting of East versus West today. And we look forward to having you all for future endeavors. We have a full schedule this Endometriosis Awareness Month. I think this was a great kickoff to that. And keep following us on she.is.lotus on Instagram for more information about our future events, not just for Endometriosis Awareness Month, but next month is Adenomyosis Awareness Month, and so on and so forth throughout the year. Thank you again, everyone, and have a great
Wait,
day.
wait, wait. Liz,
Oh,
before we go, I was just gonna say for Dr. Mangs, if he can just
mhm.
share his page again with his
Oh,
so
sure.
that for the persons who joined late, they would be able to
Yeah,
see. Thank you so
just
much.
this.
Yeah. Yeah, so we'll
Okay.
we'll leave that up and take your time to screenshot that and thank you again. And you all can slowly find your way out after you've screenshotted the information. And I'll put our Instagram in the
Yes. Thanks, everyone.
Thank
Thank you
you.
so much.
And Amy Corfelli is a very dear friend of mine, and she has a fantastic podcast on 16 years of endo. Uh,
Yes. Yes.
so I think very congratulations, Jamila, and it'll be a great book. Okay, can I stop share?
Yes.
Yes.
Okay. Thank you, everyone. Have a great day.
Thanks, everyone.
Thanks. Bye bye.
Bye.